Everybody see?
Yes.
Perfect. Well, welcome to this webinar. I'm filling in, so my skills in moderating might be in check. But so we just wanted to start by welcoming you for coming and attending this webinar. We have three projects that we're going to sort of do like a lightning session with, and just to go ahead and let you know, I'm Lauren Mullen. I am the lab director and simulation director for James Madison University School of Nursing. And I've been in simulation now for approximately, well, involved with simulation for at least about 17 years now. I joined this group and we welcome anybody to join us as well. We are a research interest group for Southern Nursing Research Society. So here we go. We have no conflicts of interest to report on behalf of all three of us. These are the presenters. There's myself and Lufei and Karen. I'm going to go first, and I think Lufei is going to go second, and then Karen. And I saw some familiar names in this group, so I'm really happy to see that. I think Nicole, I saw you in there. All right, so this is the first, this is my particular project that I worked on. I actually had two collaborators for the research part of it, but for the development of the template, it was really just an evolution over time, which we'll get into. So here are the objectives. We're going to talk about elements of the design standard, not in detail because this is the design standard was sort of the guiding framework for which this template evolved. We're going to talk about the impact of sim design on sim quality because it relates for this particular project of ours. And then some gaps in sim design practices that will support better compliance with accreditation and regulatory standards. So my template really comes together to allow you to design high quality sim, then makes it sort of easy to meet these standards. So the design standard is sort of the apex standard. It contains a lot of the aspects and elements from other standards. So I call it sort of the apex standard. But some introduction and background, design expertise that I have come across over the years. People struggle with design. There's sort of this pre-built cases. There's the NLN template that's very long. But as I started to get into the design more heavily, I realized that it was very inefficient because I ended up having to edit those cases, the relevancy of the medications, the orders, the patient status, treatments, just not up to speed with best practice. So it became really inefficient and time consuming. So I started like creating these pieces that came together ultimately. There's not a lot of templates out there. If you do your own design, you probably went through a similar process and have arrived at something that's very good for your program and your process. But there's not really a lot of options that I found where people could just pick up a template, say, here you go, and it's replicable. So that was my goal, was to be able to just hand this over and it was replicable. If you've used a pre-built case, you know they're like 20, 30, 40 pages long sometimes, and you have to sort of like pick out the pieces that apply to you. So it also felt really clunky for our operators who were just sort of trying to find this process. And also for the people who were setting up the sim. So if you are in a center where you're having students, workers, or you have part-time people that are setting up, you want to be able to give them something that is very easy to use. So as I said, non-specific, it really wasn't working. The alignment was very much not in line with our program. That was one of the big things. Relevance was hit or miss, like I mentioned with even the treatments and the meds and things like that. Very difficult to customize. And there was no like direct explicit link to the to the standards. So the aim of our study that we ultimately did was to demonstrate that the template was an effective tool to meet standards. So here, from concept to creation, we had this vision that sort of, as I was summarizing, we wanted it to also be interprofessional. We wanted it to be concise. I'm an efficiency expert, so I really like things that are concise and efficient and user friendly. So over time, we had this construction process that was multiple iterations. We wanted it to be uncomplicated, replicable, and then the impact was that this template became very adaptable and versatile, and it was the springboard for a lot of other modalities of simulation. We do simnovations, which are sort of like pre-recorded case study simulations that have 3 parts. We've done work with SLP, the speech language people. This has been published in a book for SLPs, in fact. We've also developed some other types of modalities of simulation that came about from this. And by default, if you use it, then you will meet the standards of best practice. That is the takeaway here. So let me just give you, these are a glimpse, and I know this is busy, but I'll go from left to right. If you look on the left, we have, this is just the like main part of the template where we have all the standards linked directly to the actual publication. So as you design, you're able to go directly to the criterion, look at the elements, and narrate how you're meeting that standard. Preparation, there is like how the students are prepared, pre-brief, debrief. This is just a small piece of it. As we move to the right, we have the operational piece because, you know, there is a standard about operations where we track data about hours of use, how many SPs we're using, what it's costing, preparation hours. These are all metrics that I've tracked for years. I have like mountains and mountains of data which supported some of this as well. We have set up, again, just like the ease with which you set up this particular simulation, so handing it off to someone. And then we've also incorporated the AAC and essentials, the new ones. These are the new essentials. So we're mapping to the competencies, domains, subcompetencies. We're identifying the, oops, sorry, I didn't mean to do that. I was trying to move this out of the way. So you can see we have the sphere, the concept, domains, competencies, and subcompetencies. And then we also have then the protocol, which captures like the concept above, and then we have the sim objective, and then the particular the things that meet that particular competency. So we call this like this is our patient protocol. This is what our operator uses to actually run the simulation. So this was the research part of it. So what we did is a retrospective secondary analysis. I collect post-simulation evaluations on every sim. We have a 10-point Likert scale, and we address pre-briefing elements, design elements, and debriefing elements. So at the time this study was complete, well, I don't want to say completed because we still are looking at data, but we had over 7,700 responses. Our results were that we set a benchmark mean of 8 to define high quality simulation. So for our program, pre-briefing elements, those were the means, design and debriefing elements, those were the means. So we had consistent responses regardless of the modality, what the foci was, what the level of the student. When we analyzed the data, we also found that there were some quality indicators that led to some variances, and that is inconsistent facilitation by the facilitator. So we would have facilitators that would just like pop in and pop out. They didn't really have that much experience. It was like, you know, they were loaded into that course, so it was kind of very inconsistent. Dosing, when we talk about dosing, the dosing of the facilitator, how many times they do it, and the dosing of the student. So the more the student had, then they were a higher dose versus less dose. So their experience and their response changed. That was some variance that we found. And just to add into that pre-brief and debrief expertise that we had, which was part of that inconsistent facilitation. I'm having to move this little window around, so bear with me. So, we recognize it's time for a change. We wanted to focus on in-house professional development, which we do every year. We do a CE-worthy professional development experience for our faculty, so we know that they are getting what they need. We restructured our simulations to be more consistent with, dosing was consistent across semesters. And facilitators, the number of students. We used to do 5, now we don't ever go over 4 in a room at a time. And also we used to do like a watch part handoff, the other part is watched by the other group kind of thing, but we found that was not useful. And then advocating for our sim champions versus the in and out sims. We've standardized our orientations. They are all escape rooms that they do independently. The pre-brief is a pre-brief video that we standardize so that there's no variance in the pre-brief process, and we've incorporated team planning as well. So the standardized template, we have the evidence that you can use to support your accreditation and your boards of nursing. We were told by the Board of Nursing in Virginia that our template was the exemplar for the state. I've presented this template pretty much across the nation. I've presented it at Anoxel, so internationally. It's out there. And so the benefits we see are the best practices met. It's replicable, versatile, adaptable, is CBE friendly in the current form that it's in. And there should be a link that I think Heather put in a link to a sample that you can start to use yourself. And so with that, I say thank you. And I think I'll go ahead and put the link to the template in the chat. Okay, sound good? Any questions? I think we'll do questions at the end, but if you have any questions, just go ahead and save them. Okay, so we'll move on. I think we're going to move on to Lu Fei.
Thank you, Lauren. Please continue around the slides. And I don't have a post privilege. Thank you so much, Lauren, for front loading everything here, so I can continue to transition in. Don't consider this as a 3 independent, isolated speech. It's a story about what we do. So I think Lauren, from a theoretical implementation perspective, lay out the entire landscape. I'm just gonna put my little goodie snacks in here. Welcome to our presentation on the use of the escape room simulation in undergrad and community health nursing course. This is a single group of pre-post evaluation. This project was conducted by Lu Fei Yang, other researchers, faculty from UNC Charlotte, and we are excited to share our findings with you. Next slide, please.
Just say next slide and I'll advance it.
Thank you. Thank you.
I don't want to go too far ahead or be too slow.
All right. We began by expressing our gratitude, giving thanks to the land, the people, the connection that have supported us in this research journey in the Queen City, Great Charlotte. Next slide. Clinical practice is a crucial component of nursing education, allowing students to develop essential skills. However, securing clinical placement has become increasingly challenging because of various barriers. Nursing programs nationwide face a shortage of a preceptor, high turnover, understaffed clinical site, especially community health nursing, limiting students' exposure to diverse population. When we are asked to increase enrollment every year, this unresolved challenge issues actually reduce enrollment, strain faculty, they leave or retire. Do you want to go next? The next slide, please. stay here, which further, oh, not this one, go up. No, the other way. Yeah, right here, which further reduce education quality, leading to reduced enrollment, ill-prepared graduate, and a workforce shortage. To address this challenge, our school have implemented escape room simulation since 2020, way before pandemic. I guess our leadership have a vision of this coming. As an effective supplement for traditional clinical experience, escape room simulation, I'm going to call it ERS, a novel approach offer an interactive.
Take one of them or?
Sure, I guess.
Can somebody mute?
Were they all
Yes,
working?
can someone
yesterday, or
mute their
did they-
mic?
Thank you. A novel approach offer an interactive, safe learning alternative, enhancing clinical critical reasoning and teamwork, and clinical skills. The next slide, please, Lauren. And the purpose of our study was to evaluate the impact of our ERS on community health nursing confidence among undergrad students. Our specific aim is here for you to review. Next slide, please. The ERS design was guided by social determinants of health framework, which value all aspects of human life beyond the biomedical model. It reminds educator, us, and the students that the community health nursing is not an extension of home-based med-surg floor in the hospital. Instead of a microscopic focus, students are challenged, stressed to take a broader systematic review of human life within larger social environmental contexts, rather than emphasizing traditional ADAPI, assess, diagnose, planning, intervention, evaluation, all that. The model prioritizes observation and inquiry, encouraging students to develop a team-based approach. And somebody mute, please.
Two birds, one stone. Yeah.
Could someone check, everyone check and make sure they're muted because we're getting some crosstalk, please. Thank you.
So encourage students to develop a team-based approach that empower clients as advocates rather than replacing them as providers. We are advocates, we're not providers. This model systematically teach faculty, student, it's a co-learning. It's not a feeding, it's a co-learning environment. This is a model systematically teach faculty and students how social environmental factors interact with genetic influence to shape health outcome. It highlights multifactorial nature of health issues. More important, it recognizes the growing diversity of our patient population, reinforce that not one size fits all. That's inadequate, almost unethical. Future healthcare professionals must be equipped to reduce health disparity and provide equitable care. Lauren, next slide, please. Our study employed the quasi-experimental pre-post design. Participants include 56 nursing students at a senior level 1 enrolled for this course called a community health nursing course. ERS was set up at our simulation center as a part of a skill lab. It's all built in. It's not actual research. It's integrated research. It was developed and implemented by experienced SME nursing faculty since 2020, making revisions, adaptations based on the competency requirements. It features health themes, scenarios with puzzles, prompts, case studies, students working in a team of 4, engage 20-minute session simulation home visit. The particular ERS for this one focus on assessing older adults with very complex social health concerns in a home setting. Students as a team are expected to identify environmental, physical, psychological risk, applying key community health nursing roles. It enhances its role model building and the role building process. It's a skill lab, not a lecture. It enhances critical clinical reasoning, problem solving, teamwork skill, culture, sensitivity, and humility. There is a big difference between sensitivity and humility. Next slide, please. And the data were collected at 3 time points, right before simulation, right after simulation, and 10 weeks after simulation. We are trying to looking at a short-term intermediate outcome. The instruments used include here for you to review. The key concepts are competency, confidence, perception. Next slide, please. I'm not going to bore you with this slide. It's RStudio, it's descriptive. We use a linear mixed effective model. And then we also use a visualization technique to show you the variation. Next slide. So next 3 slides, I'm gonna skip to save the time. So for here, start with the participants. And our participants are 56 students, 53 female, 3 male. They are between 21, 23, up to 42. It is a minimal confounders covariates. I'm a Harvard researcher by nature. I started Harvard study by nature for 20 plus years. This kind of homogeneous population is a treat for me. I love it. I only need a very, very minimal confounders covariates to control. I love this group. And 52% white, 21% black, and 13% Hispanic, 13% Asian contribute Great Charlotte. The Queen City had a diverse student. Language, 73% speak English only. There's a 21% bilingual or multilingual. We want that percentage to go up to goal is 50%. 50% only, 50% multilingual. The education competent, they all finish K through 12. And 82%, they all have a previous nursing experience. That's the expectation. It's a big difference between somebody never being exposed in the healthcare. 42% work in the acute care. Sadly, only 18% work in multiple places. We want that percentage to go up. 80% have never been exposed to escape room simulation before. So we're gonna skip all the way to competence 1. So now this one, next one, there. No, go up. Oh, this one is good. Thank you, Lauren. So when you examine the aggregate data and the competency show similar trend, they both increase over time. But next slide is what I like most, this one. The previous one is pretty boring. Well, no, I don't tell you anything more, but this one is very interesting. The individual student, this is show the individual student data. This one, spaghetti plots, reviews a significant variation in personal growth. The left plot, let me have a drink, not alcohol. The left plot represents competency. The right plot represents competence. When you look at the competency first, some students showed no change, maintain a perceived 100% competency throughout the semester. Do you have this type of student in your program? No comments. Where others started low and made significant leaps. Overall, most students reported feeling more competent as they gain knowledge, skill, experience. On the right, the competence plot is more complex than the competency plot. Some students experienced a significant decline about their competence level right after ERS session. This suggests that those who initially felt overconfident realized their gaps in knowledge, skills, competency level after this session experience. This indicates what that tells us, the design of our ERS in terms of intensity level, stress level are appropriate. We receive feedback. The feedback said that we're too harsh, we're too complex. It's very stressful. Our faculty all have a previous home health experience. We decided not to make them less complex. We just keep it. I think based on this, we give them a good dose of stress level, good amount of intensity, and bring them to the humility. This finding highlights competency and confidence do not always align, making assessment very challenging. How can we improve the validity of measuring both competency and confidence, or we measure something wrong? Next slide. Escape room simulation offer an innovative, engaging approach to nursing education as clinical placement challenge continues. ERS can serve a valuable alternative to enhance student learning. Our findings demonstrate that escape room simulation is an effective supplement. I said a supplement. I didn't say replacement. I don't want to get a CNE trouble. It's effective supplement to traditional clinical experience based on perception assessment. ERS significantly increased student engagement, improved critical reasoning skill, teamwork skill, helped greater confidence in real-world application of knowledge, prepare students for diverse community, peer culturally sensitive practice. From a debriefing notes, we have a large amount of debriefing notes to be published next year. It also addresses challenges of clinical placement, including site shortage, limited patient diversity, improved program enrollment capacity, faculty satisfaction. Of course, there's another side of story, limitation. There's no objective data to assess group dynamic. Since ERS is designed to assess teamwork quality, clinical reasoning, inquiry skill, observation skill, and shift from acute care to broader social context health, we must consider how to effectively measure those competencies. Traditional assessment often focus on task completion, knowledge retention, but ERS challenges students to engage in dynamic, team-based problem solving, reflecting real-world complexity. So the key questions include how do we assess the depth, quality teamwork beyond service level of collaboration? How can we measure clinical reasoning, encourage skill in a way, capture student ability to critically analyze situation, adapt to their approach? Observation skills are crucial in community health setting, where subtle the environmental social cues influence the patient care. How do we quantify that? More important is implicit bias. Implicit biases, we all have it. 100% human have implicit bias. Can shape how students interpret, respond to different patient scenarios. Should we incorporate the assessment that evaluates bias awareness, culture humility? Could a culture humility score or self-reflection exercise be used to gauge growth in this area? As ERS shift the student from a biomedical perspective to broader understanding social determinants, we must ensure our assessment reflects this transition. What innovative evaluation methodology can capture all this complexity of learning in this setting? Thank you for your time and attention.
All right, next up we have Karen. She's going to present her piece. Karen, take it away.
Thank you, Lauren. Would you be able to advance the slides for me? Okay, I'll give you the cue. Okay, as you can see with this first slide, my topic is measuring the effectiveness of disaster response simulations in a baccalaureate public health nursing course. I am Karen All, and I'm an associate professor at the University of South Florida, and I teach in a public health nursing course to BSN students. So this research study is near to my heart and dear to my heart. Lauren, can you advance? So the three learning objectives for this study, the first one was to assess the BSN students' perceptions of simulation-based disaster training using a validated tool called the Educational Practices Questionnaire, or the EPQ. This tool is from the National League for Nursing, the NLN, a validated tool. The second learning objective was to identify the 4 key educational practices of active learning, collaboration, diverse ways of learning and high expectations within disaster response simulations and describe their impact on nursing education. And these 4 key educational practices are actually part of the tool. And the third learning objective was to analyze the effectiveness of disaster response simulations in a BSN public health nursing course. Can you advance? So in looking at the background and why we decided to do this study, looking at disaster preparedness, it is in nursing curriculum, and it's needed to be there. Maybe it's not in everyone's nursing curriculum, but it does play a critical role because nurses, are involved in disaster situations. So as part of the background, we found that combining classroom instruction with simulated training can effectively enhance disaster knowledge and being prepared. And we found there was a gap. There was a lack of research using an educational tool to measure the efficacy of disaster simulation training. Next slide. So we found that disaster training using simulation is essential to prepare nursing students to respond to disasters. So the purpose of this study was to evaluate that and to assess BSN students' perceptions of disaster simulation training effectiveness using an educational tool. Next. So our hypothesis was that nursing students will gain cognitive knowledge and perceive these 4 key educational practices as important or very important to their learning. And the 4 key educational practices are listed here. So active learning. So after the students participated in the disaster simulation, during the simulation, were they engaged in the learning process? How did they feel about that? What was their perception? The second practice of collaboration. Did the students work together during the simulation to achieve a shared goal? We're measuring that teamwork feeling. Diverse learning. We wanted to see if the students were represented with their different learning styles, if they felt that it met their learning needs by participating in the disaster sim. And then the high expectation was in us knowing that all learners can meet goals with the right support. So the expectation was setting these ambitious academic goals for the students to participate in these simulation scenarios. Next slide. So the study information, first, we received institutional review board approval through our university, and then we proceeded with the study. But the type of study it was a quantitative study because we were collecting that type of data from a couple of ways. One way was we did a pre-test, post-test assessment design, and this was giving students disaster knowledge questions before they participated in the disaster sim, and then giving them after the post-test piece to see if there was any change in knowledge. And then the second quantitative piece of the study was giving them this educational practices questionnaire. As I mentioned, it's an NLN tool. It's a 16-item, valid and reliable instrument, and it measures on a 5-point Likert scale from strongly agree as of being a 5 down to strongly disagree as a 1. And this tool measured the 4 educational practices, and this tool was given to the students after the simulation. So the 2 things going on, the knowledge was given before and after, this pre-test, post-test, and then the tool was given just after. Next slide, please. So in looking at the methods of how we progressed with this study, step 1, we had our sample size, we had 145 BSN students in a public health nursing course who first received the content in class on disaster. The second step was taking that content and seeing if they could apply it to the simulation scenarios. So they were scheduled to participate in 3 disaster response simulation scenarios. One was a plant explosion, one was a chemical spill, and the third one was an active shooter scenario. These scenarios were all about 45 minutes each, the actual simulation. And then, of course, there was the debriefing afterwards. So they were all based on mass casualty incidents. So the students played the part of either an RN or a victim. And we had many victims with injuries. And the goal of the simulation was for the RNs to be able to triage the situation and be able, excuse me, to to identify and tag the victims. So then after they participated in these 3 sims, then step 3 was they were given the knowledge questions. And of course, before they participated, we gave them the knowledge questions, and then afterwards to see if there was any change. And then step 4 was giving them the tool, the educational practices questionnaire, to see how they felt about those 4 key educational practices. Next slide, please. So these were the results from our findings. From the pre-test, post-test assessment, those were the knowledge questions. There was no change. There was no significant cognitive knowledge gained. But from the EPQ tool, the quantitative results showed that the mean for all of the questions, again, it was a 16-item tool, was greater than 4. The mean was greater than 4. So that meant that the students agreed or strongly agreed with the presence of the key educational practices in the simulations. Next slide, please. So in further watering down these results here to see what practices scored, what each practice scored, you can see active learning. 91% of students reported having opportunities to discuss ideas and concepts that were taught in the public health nursing course. For collaboration, it was a little higher. 97% of students felt they had the chance to work with peers and address the clinical situation together during the simulation. Also, I want to add, as far as collaboration, we had EMS, emergency medical services personnel, also as being part of the simulation. So there was collaboration with them. For the third one, diverse learning, 87% felt that the simulation offered a variety of ways to assess their learning. And mainly I'm thinking like auditory and hearing what was going on, as well as the kinesthetic, as far as they had to, tag the victims. And then 98%, which was our highest rating for these practices, reported the instructor communicated the goals and expectations very clearly during the simulation. So that was the high expectations for the mass casualty incidents. Next slide, please. So what are the implications? Well, we found there was, of course, no improvement in the cognitive knowledge after participating in the simulation. However, most of the students believed that the simulation-based disaster training was effective in achieving those 4 key educational outcomes. And in conclusion, I mean, these findings inform best practices for teaching BSN students to learn disaster education and really helping them to prepare them to feel more confident when responding to disasters and caring for real patients. Next slide. And I'd also like to acknowledge Dr. Hernandez, Yvonne Hernandez. She is the Director of Community-Based Learning and Civic Engagement here at the University of South Florida. And she was instrumental in the data collection for this study. And these are my references. Thank you for listening. Questions?
Thank you both so much. And we are open to take questions. I'm going to look at the chat here. Okay. I'm going to put the link to the let me do that right now, to the template for you. Karen, I did want to say that I worked with an honor student years ago, probably about 2017, maybe 2016, who wanted to do ethical reasoning with disaster sims, and we did it. So she published that. So if you're interested in looking at some of that publication, it was in the Journal of Nursing. It was Greco. Her name was Sarah Greco, and she published her study on ethical reasoning and disaster sims.
I'll have to check that out. That sounds very interesting.
Let me go ahead and pull, oops, escape that. I will pull up I'll put the template link in there. What are some other questions that people, let me go back to mine. Any other questions? If you're interested in joining our RIG, our research interest group, we are happy to accept you.
Lauren, there's a question in the chat. How do you incorporate
good.
simulation into the curriculum? I have personally created a lot of simulation, and it's really based on what the gap is or what the need is for the curriculum, in my experience. So, maybe a certain course, students would benefit by having some application as a simulation. Lauren or Luffy, do you have anything to add?
Yes, right now our college is doing mapping and gapping based on the new essential. We all know simulation does not count as a clinical practice. However, we can use simulation to build all those domains. A lot of the skills can be built, like Karen, a lot of the new essential really emphasize on team-based working, the competency. We can do that in simulation environment. Even it doesn't count as a clinical practice, but it's a part of it. We do a lot of debriefing, even including faculty. We need a fully benefit use the simulation when we are not able to provide that exposure in the real clinical setting for student and faculty. So you can map, when you do your map gapping for the CCNE new essentials, keep in mind, be conscious with how I can use simulation to build them and then reinforce, initiate, reinforce through level 1 to grade level.
I would say my response is we have all of our simulations linked to our clinical courses. And the way that they structure them is they come, there's different matrices, but the one that works really well is the every other week one where they go to either lab or sim. And then the other week they do clinical. But with AACN, we know that our mindset is switching from augmenting clinical hours with sim. We can do 125 on Virginia. We can do 500 minimum of that 125 can be simulation. So we've been in this mindset where we want to increase the number of hours, like try to get to our top number. We have to back away from that because we will not be able to achieve that using sim to assess competency. So we will go from a model where they're there for 2-3 hours to a model where they may only be coming for 20-30 minutes at a time, and they'll do more rapid individualized simulations versus the group format. And we've talked about this in our interest group about competency-based tools for groups that are really few and far between in nursing. They're there for other disciplines, and they're very general, but we need more research about competency-based tools for groups in nursing. So that would be my response to that.
There are several questions for Karen. Do you use a FEMA scenario for MCI? There's another question about it.
Currently, no, not FEMA scenarios. These scenarios were created by faculty. As far as, let's see, ensuring emotional safety during the disaster drills, that is a very good question. I also do psychiatric simulation scenarios. And, we can get into some really sensitive areas with these simulations. And we do have support services during the simulation in case a student would need to talk to somebody. So we do have an office of well-being here at the university, which is very helpful to support our students. So we refer them for additional help if needed. Is there any
I
other
can
questions?
put-
Yeah.
There's a question about how design. Yes, based on what you're doing, everything we do is driven by the competency, CNE competency. If, for instance, for the skill lab, you have to schedule OSCE the whole day. For simulation escape room, this one, it's when they were taking the lecture course first, and then we bring them to the simulation lab. So we kind of build it in. We need to be creative. I absolutely understand. It's hard to schedule.
I'd like to add, there was a question about fitting in the simulation time. And our simulation is considered part of the clinical time. So it is scheduled for students, is mapped out into their schedule. It works around their other clinical days. So each student is scheduled a certain day for simulation, depending on the course.
We also count 2 for 1 for our high intensity simulations. The Board of Nursing hasn't defined it, but I'm on the board of directors for the Virginia State Simulation Alliance. It's a grassroots sort of organization that our president helped to establish in Knoxville. So we have this grand history in our presence, but we inform the Board of Nursing on regulations. We're very influential in that. And we defined what's called in high intensity SBE. And it's on the template. We have a descriptor of a high intensity SBE and what defines it. So if you're looking at ratios in your programs, Virginia doesn't regulate, but we decided that we will count 2 for 1. So
We're also 2 for 1 too. We're 2 for 1 as well.
okay, yeah. And there's a link in the Anoxville website that'll tell you what the regulations are for each state. I don't know if anybody's ever looked at that, but it's a very good resource to look at other states and see what they have on their books in terms of regulations.
Lauren, did you address this question? It says, I would like to hear a brief description of the ERS used in a community program.
Yeah, I will email. Once I send it, put an email address in the chat. So.
Oh, okay. I'm sorry.
Okay, let's see.
Sandra is asking the site. Lauren, do you have a site for them to look it up? The
Which
ratio.
one was it? Oh, the website. Let me find it. I'll
Yeah.
I'll be right back. I'll go look for it.
And again, please come to our rig. All the questions you have, we discuss every time. We're just doing commercial for our rig. It's really great place for everyone who are interested. Initiate advanced simulation.
So when you go to the map, you just click on your state or whatever state you're interested in looking. It's nice to see like a pretty broad and some states they don't have anything. And you can cite it in any research that you do. There's been a lot of research on, I don't want to say a lot, but there's been some research on regulations in terms of maps, ratios, and anything that related to like hours, those kinds of things. So you might, it's nice, a nice summary to use.
Okay.
Thank you, Nicole, for the shout out. This is great. We actually had several people come from out of state last year. We're trying to build that, and it's only a $50 membership. I'm just saying, but it is a lot of homegrown stuff. There's a lot of homegrown stuff in there, and we really do a lot in Virginia. So, anybody else have a state alliance for sim? Might want to get that going. All right. If there are no further questions, I think we're good to go, everybody. Thank you for
Right.
coming.
Thank you.
If anybody wants more resources too, I've got lots of resources. Buffet and Karen, thank you so much for assisting me.
Oh.
in that. I'm not a good host.
Thank you, Lauren, for being the slide turner.
Yeah, you're wonderful. Thank you so much.
Yes.
I
It was
just
very
like I feel like I'm too informal, and I talk with my hands all the time. And but nice to see you all. We'll see you again soon for our next meeting. Thank you, everyone.
okay. Thank
All right.
you. Bye-bye.
Bye.